Director of Terminology, and I'm excited for our topic today, which is on our process of instrument assessment, and we have some guest speakers. We're going to let individuals come into the call, and we'll formally kick off the call usually at 3 minutes after the start of the meeting, just because of the need to transition. So again, welcome. You are in the right place, and we will kick off very shortly. Welcome, everybody. And we are going to kick off in about 2 minutes. We historically give about a 3-minute buffer for folks to roll over. If you want to, as you're joining, put in your name and the organization you hail from. That is always helpful, and then we can ensure that it's collected as part of our information from the meeting. Again, I'm Sarah DeSilvi, the Director of Terminology for Gravity, and I'm really glad that you all are here. Thanks, Tom, for going first. I see friends from AHIMA. I was just at the AHIMA conference in Salt Lake and had a lovely time. So it's good to see AHIMA friends here. We are ready to kick off. And happy Halloween to everybody. Oh, nice, Lucy. For everyone, I was wearing my flower crown in earlier meetings. I'll make sure that it's not on my head right now because it's a little distracting, but we're really glad you're here. Again, Sarah DeSilvi, Director of Terminology for Gravity. And here we are, the Gravity Implementation Affinity Group. Welcome you all. Nice. Barrett, Vanessa. All right, next slide. As a standards development entity, it is our responsibility to comply with antitrust practices. All Gravity Project participants have the responsibility to comply fully with federal and state antitrust laws. This is both explicit and interpreted, so adherence to the guidelines involves not only avoidance of antitrust violations, but avoidance of any behavior that might be so construed. Next slide. And so just briefly, what is Gravity? Where are you? We see a lot of friends here, but there are some new faces. Gravity is a collaborative initiative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. We're glad you're all here. Next slide. Gravity would not be Gravity without our members and sponsors. So we're lucky to have a lot of support across the ecosystem to support what we do. We also have a fairly unique governance structure that, in addition to our member sponsors who help support this work financially, we have a designated membership structure which allows critical voices from direct care organizations, community-based organizations, and those entities directly working in grassroots areas on social care to be part of our governance. And we're really grateful for all of their voices and the time they take to do this collective work. We also have special thanks to our in-kind friends from CMS, American Medical Association, and Civitas, who are our partners in implementation with this meeting. Next slide. As you join, so just as a reassurance, all of our meetings are recorded, and the recording is available on the Affinity Group Confluence page after. But since midsummer, we've been actually leaning into topics that are significant enough that they will serve as legacy webinars in our reference library and resources for implementation. And we've been constructing topics and implementation specifically to answer like ecosystem-wide questions. This meeting topic is one of them, so it'll be both available in the meetings recording page and in the resources for implementation on the Gravity Confluence. Muted upon entry, raising your hand to chime in with questions or comments, and as anyone who's been in a Gravity call knows, although we are a formal consensus-based initiative, we really welcome your voices. So please feel fearless about that your voice matters and be part of the conversation at any point in time. Next slide. This topic is one that if there's any email that I get the most as the Director of Terminology for Gravity, it's on this topic, so we thought we'd lean into it. This topic is specifically supporting entities that want to understand how we assess instruments for acceptance within the Gravity subject matter expert and evidence-based process. We're going to overview the national policies and programs that reference Gravity accepted assessment instruments. We have a special guest, our friends at NCQA. Thank you so much for coming to join, because certainly some of the most of the emails we get are about the health equity accreditation process and what entities asking whether their ecosystems instrument aligns with Gravity specifications. They will also be presenting on the social news screening and intervention measure, which is one of the policies in the ecosystem that points to Gravity standards. I'll then run through how we assess instruments, and this will again serve as a webinar of reference so anyone in the ecosystem can understand how we do that. We'll have an open discussion, and then we'll wrap up and close at the end of the hour, and I'll flip to my next meeting, which is the Gravity Terminology Public Call. Any questions on the agenda? Thank you so much. I'm ready to kick off. And again, listen, I think we might have inverted your name on this. My apologies. Listen, I'm really sorry because I think we put your last name first.
No, you're not. You got it right.
Oh, we did get it right? Okay, there we go. I messed it up. I know in one of the instances. Awesome. Thank you. All right. So thank you so much for coming. Next slide. Just a community announcement. I actually just was part of this kickoff this week. We wanted to let everybody know that the Assistant Secretary for Technology and Policy, ASTP, Health Information Technical Advisory Committee, HITAC, of which I am honored to be co-chair, has formally kicked off and convened the Health Equity by Design Task Force. There are a series of links on this. We had our first public meeting on Tuesday. There's a series of public meetings going forward. We welcome you all to attend. The purpose of that is to provide ASTP with purpose of the task force is to provide ASTP with recommendations on promising practices, challenges, and resources to support health and human services organizations to incorporate health equity by design principles into the design, build, implementation, and use and monitoring, ever so important for health equity, of health IT. There's a second link where you can find the schedule of all the meetings and accessing the links, and we really want to make sure you all come. So as with most high-tech meetings, everyone's welcome to attend the whole meeting, and then there is a period of public comment at the end of this meeting. Again, it's all very much supported by our friends at ASTP and Dr. Tom Mason. So grateful for this convening, and we welcome you all into it. And there's more information at the web pages that are offered in the links there. And they should be in the chat shortly. And then I just want to note that we do have a lot of Gravity friends in that group just because of our past work. So grateful to see faces and friends from the Gravity space in that space as well. Next slide. I'm going to start with just a very brief overview of the policies and programs that talk about Gravity's curated value sets and list of accepted instruments. And then NCQA is going to go in next. So next slide. So because of gravity convening subject matter experts that assess every single instrument that is sent to us, we quickly became the authority for collections of evidence-based instruments. So gravity accepted assessment instruments and Loink encoded value sets now serve as the reference for national policies and quality measures across the country. I'm separating out policies and electronic quality measures because there's different standards here. The policies that currently point to gravity assessment instrument value sets are many. Examples are guidance on approved instruments or accepted instruments for CMS special needs plan, social risk assessment, annual wellness visit assessments, guidance for instruments that can use for compliance for the social terms of health, risk assessment, HCPCS concept. And then, there's other regulations out there as well. And then also, as NCQA will present today, the process of using evidence-based assessment instruments in line with NCQA's health equity accreditation process. They will talk about that ever so shortly. In addition, I didn't put USCDI here, and I should have. My apologies. I have a fair number of presentations this week. In addition, there are regulations and policies that point to the Loink encoding of those instruments. Again, I'm going to highlight the fact that HTI 1 references the social terms of health approved concepts and data elements within USCDI v2, of which gravity is the curator of those collections of instruments and all of the associated other elements, including goals, diagnoses, and interventions. In addition, the current NCQA social needs screening and intervention measure that our friends at NCQA will present on shortly also references the Loink encoding of those instruments. And in addition, the incoming CMS addressing social needs assessment intervention measure also references the Loink encoding requirement. This is because they are electronically reported. As we'll discuss in a little bit, and we have discussed on other calls as well, the CMS addressing social needs assessment intervention measure raises the bar on or for validity within their requirements as they're able to do. But again, the base gravity value sets are the reference. That measure is going through the MUC measures under consideration process right now, but CMS is authoring that measure in line with gravity and has presented on that in other areas. Which is why we're centering NCQA today. Next slide. Any questions on this? So if we go back, I had one slide on this. Any questions on the general policies out there, right? There's regulations that say, if you want to use an evidence-based instrument, look here. And NCQA's health equity accreditation, we'll present on that very shortly. And then there's other regulations that raise the bar to require Loink encoding. I don't see any questions on this. Okay, so now we're going to center our dear friends, and Polita, my apologies for mixing up your name a couple seconds ago. We're excited to have our friends from NCQA that we communicate regularly with present on their health equity accreditation process and the social needs screening and intervention measure. Kick it off, and then I'm going to talk about how our instruments feed up into that program.
Thank you so much, Sarah. My name is Paulina Lisson. I am a senior healthcare analyst at NCQA. I am in our Health Equity Sciences Center. And apologies, is there a lot of background noise that you hear? They decided that right now was the perfect time to start leaf blowing outside of my apartment.
We hear nothing. So.
Okay, perfect. So I'm a senior healthcare analyst at NCQA in our Health Equity Sciences Center. I work on a variety of equity-related performance measurement projects. I'm going to walk you through our social needs standards and our quality measure. And full disclosure, I am more on the measurement side, so I will be presenting information about our accreditation programs, but that is less my expertise. And then I'll give you the opportunity to ask any questions at the end. Next slide.
The next slide. This is an error on my part. Keep on going. There we go. Thank you.
Okay, next slide. Perfect. So first I wanted to provide an overview of NCQA equity initiatives across the organization. So NCQA has three primary levers to advance principles of health equity. Those lanes of work are all interconnected and each in turn support each other's objectives. So the first of the three, research and partnerships that identify and amplify best practices. So for example, our effort to develop a birth equity measurement framework with a community reproductive health organization, as well as measures that give organizations the tools to make data-informed decisions, monitor, and improve. So that includes the social needs screening measure I'll be talking about today, or the effort to measure or to stratify measures by race and ethnicity. And then finally, the standards that provide guidance, structure, and accountability, health equity accreditation, which I'll refer to as HEA and HEA plus. Those distinguish organizations as a high quality business or community partner that has an ongoing commitment to health equity. So our HEA Plus program is where we require organizations to directly collect social needs that I will get into later. Next slide. That brings us to our overview of the HEA Plus program. So this set of standards really emphasizes cross-sector and community partnerships to promote collaborative relationships between healthcare and its community. So on a high level, HEA Plus distinctions are given to organizations that collect community and individual level data, foster partnerships with CBOs, promote interoperability and data management between partners, develop programming to prioritize and address social risks and social needs, and ultimately track referrals for social needs resources. Next slide. The first section of our requirements for HEA Plus is related to the collection, acquisition, and analysis of community and individual data. So this section of the standards outlines a variety of elements that organizations need to demonstrate. That includes defining their communities with geographic and demographic data, acquiring social risk data from communities from like local public health initiatives. So like that includes data on air pollution, water quality, poverty, other neighborhood characteristics, asking individuals directly about their social needs, conducting analyses to identify disparities and differences in risks amongst different populations, annually conduct risk stratification and population segmentation to report how population characteristics are shifting. And then based on all that data, identify social needs and social risks to prioritize addressing. And then next slide. If we focus in on the requirements around collecting individual social needs directly, the language in the standards allows any assessment tool to be used, whether it is internally developed or an external screening tool. There is a catalog of examples of assessment tools that can be used, but there's not a list that is required explicitly. The requirement around screening is that organizations are asking about at least 6 domains. That includes food, housing, transportation, financial insecurity, interpersonal safety, and any other 6th domain. And to get HEA Plus accreditation, organizations need to demonstrate a framework for direct collection. So the frameworks are typically going to involve, defining the population that they collect data from, the timing, the setting that those assessments occur, the staff responsible, the scripts involved. And those standards also allow for organizations to report exchanged, stored, collected data from other systems, including CMS, local state agencies, federally qualified health centers, HIEs, case management systems, so on and so on. And so all this to say, a variety of sources for individual social need data are accepted, but the requirements around the 6 domains and demonstrating a framework are the more rigid parts of the accreditation program. Lucy, can I answer your question right now?
Yes. I'm interested that you don't either recommend or require a specific screening instrument for social needs. Since you don't, how does that affect attempts to look across systems, all using different instruments and therefore different definitions and so on and so forth? How does that affect ability to compare how social needs data are being used across systems?
That's a great question. So the HEA accreditation is a bit more of a organizationally specific distinction, and that's why we coincide. We have multiple levers that we are using to advance social needs at NCQA. What I'm going to get into next is our social need screening measure, and that's where we require standardized tools, because that's really like collecting population level data across health plans across the country. And that's where the requirements become more rigid because of that use case of trying to compare. So that brings us to our next slide. Shifting away from our standards and into our social need performance measure, this measure was published in NCQA's Healthcare Effectiveness Data and Information Set, also known as HEDIS, for measurement year 2023. The social needs screening and intervention measure assesses the percentage of members who, during the measurement period, were screened for at least one unmet food, housing, and transportation need using a pre-specified instrument. And if screened positive, they received a corresponding intervention. So the measure has 6 indicators, one each for screening and intervention for each of the social needs. The measure is reported by Medicare, Medicaid, and commercial health plans using electronic clinical data systems. Individuals are excluded from the measure if they are in hospice, enrolled in special needs plans, or in long-term care institutions. And the measure is specified for all ages, and rates are stratified by different age groups: children, adults, and older adults. Next slide. Our current measure has 3 domains, which are food insecurity, housing insecurity, and transportation insecurity. Next slide. And to clarify, housing instability, homelessness, and inadequate housing are subdomains of the general housing insecurity domain. And to fulfill the measure requirements, plans are required to ask at least one housing-related question that is under the housing insecurity domain, not necessarily about all 3 subdomains. Next slide. So the way that our measure is calculated is through 3 screening indicators and 3 intervention indicators. In indicator 1, the denominator includes all members continuously enrolled during the measurement year. And the numerator captures individuals with a documented result of screening via a LOINC code. So this indicator only captures out of the plan's population who was screened. In indicator 2, an intervention indicator, it captures members with at least one positive screen result via the LOINC code. And the numerator captures members with an intervention that can be that is tracked to an administrative source, such as a CPT code. So ultimately, intervention indicators assess, out of those who screened positive for a social need, what % received a corresponding intervention within 30 days of the positive screen. Next slide. So, yes, okay. So here's an example of a screening questionnaire. So taking different questions from different tools, so long as they have an associated LOINC code, is allowed. And then the measure specification language also allows for cultural and linguistic adaptations to the standard screening tool. So for example, this questionnaire has the hunger vital sign food insecurity screening question. The responses that are considered positive are bolded. The housing question, that is a prepare question about fear of losing housing, and the transportation question that is from Health Leads. Next slide. So here's an example of a documenting an intervention. A LOINC code is associated with a positive food insecurity screening is identified. And then a referral for a community meal service, for example, is an acceptable intervention. And we look for documentation of that service referral within 30 days from that original positive screen. Next slide, please. Here are some examples of intervention types that are included in the measure, which are defined in Gravity Project value sets. The interventions included here are categorized into 8 types, including assistance, assessment, coordination, counseling, education, evaluation, referral, and provision. And though our intervention indicators require documentation of one of these types of indicators, they don't require at this point closing the referral loop or getting confirmation of receipt of services. So you'll see referral here as an appropriate intervention type. That means that a referral has to be placed within 30 days, but not necessarily that the patient receives the service within 30 days. Next slide. Next slide.
Might just be a delay.
Can I ask a question while we're waiting for the slide to
Yeah.
turn?
Yeah.
Absolutely, Diane, just make sure. Yes, please do. And then there's a Bijan, this presentation was for you. So just so you know, not just for you, but your question's very apropos. So thank you. So I'm going to work on the background. So Corey, you ask your question, and Paulina, you can.
Yeah, so maybe and I think you're saying this, but I really want to confirm it. So to comply with these measures, I must, if I'm participating in these measures, I must demonstrate that I used these standardized codes to calculate my numerators and denominators.
Yeah.
Uh-huh. And how is that to assess that sort of compliance? Is that just sort of I attest that, yeah, I used LOINC? Because I mean, to say, or, how do you assess compliance with that particular, terminology part of the measure?
Yeah, that's a good question for our auditing side. I'm more on the side of developing the measure than employing it. So we have a whole section of NCQA that is responsible for partnering with health plans, auditing the data that they submit to us, answering their questions, and working more directly with data submitters.
And also, Corey, I can testify that we know from our vendors that they actively map all of the requirements, all of the observable interventions and screening instruments that they have within their records into these standards in the background to support entities in reporting for NCQA. So if they're not directly mapped, matched by the point of the
Captured. Yes.
Yeah.
Okay.
And
Okay, great.
then those are uploaded and sent, to attest to NCQA. They have an attestation portal, right, Paulina? It's a little bit, yeah. So it's a little bit, yeah, 100% though. That happens, is happening all the time right now because of the work of this measure. And then is it okay to? I think this might be one of your last slides, right, Paulina? Because there's some other questions that we have, I think.
Yeah, I have about 5 more slides, so I
Okay,
could.
so I'm going to hold some other questions because I have questions, and I saw Bijan's questions. And Bijan, this is why we created this presentation. So let's let you go through the rest of your slides, and then we'll have some good time for questions and answers. Thank you so much.
Okay, sounds good. So this past summer, we conducted our first year analysis on the 2023 data that was reported for the SNS measure. And that first year analysis process is standard for all of our HEDIS measures, and it determines if we move the measure into a public reporting status or not. The 3 key facets of the first year analysis included examining health plan ability to report the measure, performance rates of all the indicators, and then particularly for our electronic data systems or measures, we look at the breakdown of the data sources that were used to report the measure. So for context, public reporting is basically, it's an NCQA distinction for measures that means that we are recommending that the measure be used in programs, including our accreditation scoring. So there are next slide. There are a couple of key findings which we wanted to share with you that have shaped our strategy for the next couple of years with the measure. The first finding is that performance rates were varied, which implies that the measure is meaningful and useful for comparing health plans. There were plans that were reaching intervention indicator performance rates of up to 100%, which suggests that some plans are not screening their general member populations and instead targeting populations that they assume have social needs. So that indicates to us that the measure is useful, that it will contribute to improvement in wider screenings. And the screening performance was below 5%, which despite about 70% of plans being able to report the measure. So overall, all of those findings imply to us that the measure is meaningful and helpful for comparison between plans. So secondly, we found that a large portion of the plans were reporting rates of 0 for screening indicators, and a lot of plans were unable to report intervention indicators due to small denominator sizes. So some of the age group stratifications didn't have enough commercial plans to be able to report those specific rates. And so therefore there were not sufficient numbers for benchmarking, and those benchmarks are a key feature of public reporting. So that indicated to us that commercial plans are not really ready for public reporting of this measure, and we need to give some time for data systems to adapt and improve. And we overall made the decision to not move forward with public reporting for any product lines for measurement year 2024, but assuming that we will reevaluate this decision once improvements in SDOH documentation are further implemented. And lastly, part of this decision to not move forward with public reporting is related to this last finding, where we analyzed the data sources used for measure reporting, specifically the distribution between electronic health records, health information exchanges or registries, case management systems, or administrative data sources. And as previously mentioned, our measure spec allows for use of administrative codes for reporting only the intervention indicators. And we found that around half of the data for interventions was from administrative codes. So that suggested to us that health plans are making use of administrative sources when our measure accepts them. And because our measure doesn't currently allow for administrative codes to be used to report the screening indicators, we saw a lot of data availability challenges, and we're looking to reevaluate our measure and try to facilitate easier reporting by adding G and Z administrative codes. So this intent to reevaluate also contributed to our decision to not move the current version of the SNSE measure to public reporting. Next slide. So a key consideration of ours is also the policy environment and the current state of social needs in the greater field. And if you hit once. There are upcoming requirements for adoption of health level 7 standards, FHIR. There's SDOH elements that are mandated by US CDI and integrated into Gravity project value sets that we're going to continue to align with. Click once. In terms of data collection, you can click again. Okay. In terms of data collection, new G and Z codes were added in the 2024 physician fee schedule. And a slow uptake of G codes has been occurring in clinical settings. So only in 2022 did Z codes include codes for food, housing, and transportation needs, but documentation with Z codes has been steadily inclining. And then there's also payment policy that shapes reimbursement and incentives for collection for documentation of social needs data. So overall, we see how social needs data is increasingly a policy and industry priority, and we want to align our measure with the direction that the field is going. Next slide. So that brings us to our next steps for the measure, which are going to include an evaluation of the addition of G and Z codes to our measure. So we are tentatively planning to make those measure updates in order to move the new version of the measure into public reporting for measurement year 2026. And then in future years, we're going to consider the addition of more social need domains or develop a strategy for closing the loop on referrals that we continue to make the most relevant updates to the measure that align with the goal of comprehensive social need quality measurement. So that is my presentation for you guys. I am eager to try to answer your questions.
I hope it's okay to start with, I'm going to start with my question. I hope, because that's the reason why we did this in Bijan. This is part of it. So I have two, one, a statement just of note, and Polina's aware that the incoming CMS measure addressing social needs assessment intervention does center Z code documentation as well. So NCQA's move will be in alignment with CMS moves, and so they always try to move in sync. And then if you could help attendees understand how gravity fits in with the health equity accreditation element. The social needs measure is very straightforward. We curate the value sets that you all reference. That's very, very clear. But help me and us understand if we have a role in the health equity accreditation process and what that role is.
Yeah, that's a good question. I wish I had my standards, the coworker responsible for standards on here with me. She probably can speak better to the requirements. But I think that Gravity Project, has a role in the greater industry for the standardization of the documentation. And there is that component of the HEA Plus program that is looking for facilitating interoperability between CBOs or other partners and healthcare organizations. And so I do think that that is an important way that Gravity Project comes in, is actually being able to exchange data and having standards for that data. I guess aligning with the field so that there's actually an ability for healthcare organizations to communicate with their partners.
Fantastic. I think more to come on that too, because Gravity wants to understand its role, how to be helpful as well. And Bijan, I think that relates to part of what we've been communicating regarding Gravity's trying to understand its role in that process as well. And so now raise hands, everybody. We have this amazing opportunity to ask questions on NCQA, and again, understanding that Polina is an expert in the SNS element and does not have her health equity accreditation partner here, correct? But go for it and ask questions, raise hands. We're ready to have them, and we'll try to elevate things in the chat as well. Corey, you had a question. Bijan, you had a question. Corey, do you want to ask your question now?
Yeah, sure. Yeah, this is just, I have a hard time kind of connecting the dots on sort of what's driving use. And, so my question is, let me read my question. It's about who is using these measures and why are they using these measures? In other words, what are the incentives for complying with these measures? And that might be a dumb question, but that's all right.
It took me a while. It took me years to be at NCQA to even really understand that too. But basically, like NCQA's measures are all published into HEDIS, and the HEDIS measures are constantly referenced in like different accreditation programs, or also like different compliance programs. So in order to none of the SNS measure has been required, but it, like on a national level, it depends on more local policies. So there are some Medicare policies that require gathering of social needs. So those organizations that are providing Medicare plans are mainly some of the contributors to this SNS data that we saw. And so there's a network, I guess, of incentives depending on local, like state policies or reimbursement policies to be in compliance and demonstrate quality improvement and quality measurement within organizations. But that is like a very general overview, and I can reach back out to you with a bit more of a specific with more specific policies after the call, if that would be helpful to you.
And we can circle background information for everyone attending. Corey, just as a reference, like in most, in my value-based care world in Vermont, our reference of value-based performance are the HEDIS measure performance. So, and we select different measures of reference for it to be the measures of importance for whatever cycle and measurement year we're working in, but it's always the point is always, the base is always HEDIS. Lucy, I see you have a question.
I was just going to add to what Polina said about local policy. I think and someone on the call, please correct me, to be a Medi-Cal health plan, NCQA accreditation or certification, I'm sorry, I don't remember what the right word is required. So that may be, that's certainly an incentive for a health plan to get on with this. If that isn't true in other states, then the question is still on the front burner. Why do this? Thanks.
And we certainly know our gravity payer members are are keenly aware of the NCQA measure, and you know, it makes me think of our partner, our many partners who have spoken on implementation, Affinity Group, as the driver actually for implementing gravity terms, being the SNS measure. So grateful for that partnership as well. So Bijan, do you want to ask? Sorry, Polina, yes.
I was just going to add a bit more context that it's about like, I think over 90% of America's health plans report HEDIS measures and are in compliance with different certifications that NCQA provides. Yeah, so that's kind of the reach. It is big, but then the measure by measure level kind of depends on local policies, like in California.
Thank you. And then there's some really good questions in the chat, and I'm going to try to keep things going. So, Bijan, do you want to ask your question since you asked it in the chat a long time ago? Because this was 2:55. You asked your question. I want to make sure it gets answered.
Well, first of all, Sarah, thank you for helping address this question that we had. And just to give some context, so I'm from state of California with Riverside University Health System, and we're working with our managed care plan and where we have our local assessment that we use for the past 8 years to be able to screen for social needs. But our managed care plan let us know that we'll need to get it NCQA accredited to help us know that, you know, anything that we screened and provide intervention for, we can help provide reimbursements for the activity that we have, and also be aligned with some of the state policies and national policies. So when we met with NCQA about a year ago, they hadn't let us know that for us to get our internal assessment vetted, we'll want to connect with the Gravity Project just to make sure that, you know, the questions are asked appropriately, and if there's opportunity for us to revise our instrument to be able to you know, match the accreditation, we wanted to be able to work with that. I think the only question is about the alignment of the questions itself. So there was 3 questions. So with food insecurity, transportation, and housing, our internal assessment did seem to be gravity aligned, but the housing question, I think that's where there's a lot of dialogue between our organizations, where we had our own native housing questions, but then to get it, you know, approved, I think that's where we were not too sure how to move forward. We had other housing questions that were within our electronic health record system that had been built out, but then to also add more housing questions, we have to work with our vendor and other folks to make sure that they can actually develop it out and integrate it to our electronic system. So we're trying to find a best path forward on making sure that we could get our assessment NCQA approved. But I guess the main question is that, you know, for the 3 housing questions, we had been informed that we had to screen independently for housing inadequacy, homelessness, and stability. But for this measure, if NCQA is saying that we just need one of the 3, would we be okay to say that this is an approved assessment?
Yes, I think that part of we have had this question a lot. I think it has gotten confusing with the subdomains underneath housing insecurity, but to fulfill the measure, you only need to ask one housing question. That is any part of it, that is part of any of the subdomains. Oh, sorry, go ahead.
No, you go, and then I'll follow when you're ready.
I was going to say, I am not sure what the process is for like actually giving out the NCQA accreditation and like the rigor to which the assessments are looked at by auditors for the accreditation distinction. But because the language is pretty it's not very rigid in the screening tool type that it requires, only that there are those domains that are asked about. I believe that that assessment would fulfill the accreditation standards. But then for the measure, as long as you have that associated LOINC code, because from the measure perspective, we need something standardized, we need something coded in order to be able to track that information. And so if there is an associated LOINC code for any of the housing subdomains, then that will be carried up into fulfilling the housing insecurity domain of the measure.
I'm going to try to wrap up what you said and circle back, Bijan. It's new as of last week. Oh, sorry, I hate it when the hand automatically comes. New as of last week, it was my understanding. I know.
I had no idea.
I know my camera. So, new as of last week, it was Gravity more deeply understood because of this meeting, how to support the accreditation process. And so this is literally stemming from last week. So this is part of why we had this call. And so to align with the measure, which is a little bit stricter, even just from the accreditation process, if an entity has a basically valid alignment within housing for purposes of gravity, if it all rolls up into housing insecurity in the measure and all rolls up into housing insecurity in the accreditation process, meeting 1 is okay at this time. And that's brand new. And I haven't had a chance to circle back with you in an email, but that helped us. And we're going to quickly go into the next section on how we validate those instruments. But that was brand new, and Polina can testify. We talked about that at the meeting we had to prep for this, and that's Gravity's understanding going forward. We do assess any instrument domain by domain. We'll talk about that in a couple seconds. But for the purposes of NCQA, you don't have to meet every single one of the subdomains of housing insecurity. And that's our understanding going forward to support NCQA in the accreditation process. And we can circle back more, and we have further meetings with NCQA planned in the future, but just noting that. I see one question regarding number of EHRs that have LOINC encoding. I think is worthy of an Affinity meeting on its own, but I can testify base updates to most EHR vendors include LOINC encoded instruments to align with this measure and align with USCDI. I saw a specific call out to Epic, and I want to just dispel that because I can testify for sure that Epic, according to its updates for the past few years, have had hard-coded LOINC encoded USCDI aligned social determinants of health instruments as the base core update. Whether or not an entity accepts that update or imparts that into a local instance is another thing, but I just want to answer that question. And it seems worthy of another implementation topic to bring our vendors together to talk about implementation and design from a vendor perspective. I don't know if we have a vendor, an EHR vendor on the call right now, but just want to make sure everyone is aware that work is happening to support both this measure and other policies and drivers as mentioned in the beginning of the call. Whew. Lucy, and then I'll talk about how we assess instruments.
Yeah, thank you, Sarah. One of the virtues of the Gravity process is that we have such a diversity of experience and expertise in all our calls that all of us learn just how complicated these social determinants are. And so when I hear that NCQA only is okay with only reporting one thing about housing, I'll just say that I really hope that changes really fast. And I hope that Gravity will encourage NCQA and equivalent organizations to recognize that questioning a patient about housing and only reporting one thing that they say doesn't work from the patient perspective. Thank you.
Yeah, thank you so much for your comment, Lucy. I think that illustrates a really complicated balance that NCQA is constantly striving to achieve, of the balance between feasibility and reportability, and then the specificity and the data quality and the the potential gold standard. If hypothetically, it would be great if we could also get data on if patients are actually receiving their services, or ask about many more social needs domains like utility insecurity or financial instability. But we really see social needs this SNS measure as kind of like the starting point. And we're trying to be able to not make the requirements so high that we're able to fold organizations in and make this a feasible measure for organizations to implement. But you know, like I said at the end, like we're always looking to align with the field and make improvements to the measure that will align us with the highest possible standard for quality measurement. But thank you, everybody. I will try to answer as many questions as I can in the chat over the course of the rest of the presentation.
Thank you so much for coming. And again, just because you can imagine these questions are only a fraction of the questions we've gotten in the ecosystem, and just noting our longtime collaboration with NCQA. I'm now going to pivot to, and Pina's probably going to start answering questions in the chat just to help entities understand how we assess instruments. And then I do want to note, per any Affinity call, it's really great. Great opportunity for a different Affinity call and another topic. Just when we think that we're done with topics, there's something else to lean into. So just thank you for the EHR questions, and I hope I did a general overview that hopefully addresses some questions there. Paulina, thank you so much. NCQA, thanks so much. And now quickly updating on how we do what we do. Next slide, because the how we do what we do is partly why it's referenced in federal regs and guidance, is because it's so formal. So this is how Gravity assesses social risk instruments for acceptance. Again, this will be, again, as a reference available on the Confluence, both talking about NCQA and our alignment therein, both across health equity accreditation and across the measure, and also about pointing entities to how we do what we do. Next slide. So the need for social risk assessment drives development of standardized social risk assessment instruments, right? This is a gap. We want to understand people's social needs, and so instruments are developed. Important thing to note that any gold standard instrument is validated at the domain level, and Lucy was just talking about this, right? So there's a food insecurity instrument. Specifically within housing insecurity, it's complicated enough that instruments are validated often at the subdomain level. HUD just put out its housing insecurity instrument as part of its many-year cognitive testing. It has concepts of housing instability and inadequate housing both in there, but it's all broken down by subconcept. In general, the science of social risk assessment is pretty young, so there's not a ton of gold standard instruments out there in the ecosystem yet, and so this limits the ability to fully validate instruments and analyze them. There is the USDA food security module, which has been the gold standard since the 1980s. It is such the gold standard that it is the model for all international food security assessment, including variations across Latin America and Asia and Europe and the subcontinent of Africa. So it's so much the leading edge of the design and understanding of food security that it is replicated across international use. And it also, as I just mentioned, HUD is leading development of the Housing Security Index. They just published its first draft. It went through like 3 years of cognitive testing, which is a kind of testing at the administrative level, directly with patients and entities that are being measured. And now they have a brief that's out in the ecosystem. It's going to be in the chat. Anytime you develop a brief pragmatic instrument that's suitable for coupling and grouping into a comprehensive instrument, they have to be tested against those gold standard instruments for psychometric alignment. Psychometrics is the science of measurement. And so, like, for instance, the hunger vital sign, which is a very widely implemented food insecurity screening instrument, the 2-item hunger vital sign, it was validated by testing it against the USDA food security module. And so that is the best in class, testing requirements. The limit of gold standard instruments limits the full testing of brief pragmatic instruments logically. So often entities create comprehensive instruments to streamline screening. Again, this is incredibly nerdy, but I say this over and over again in emails, so this is the time to say it once. This is how Gravity does what it does, right? So often entities create comprehensive instruments to streamline screening. Brief assemblages like the Accountable Health Community's health-related social needs instrument, right? Which is food insecurity, inadequate housing, housing instability, homelessness, right? But rarely are these comprehensive instruments fully validated for all domains. So there is a full validity gap in the ecosystem. You can see our friends and Gravity co-founders, UCF Siren, on this topic in the webinar linked in the chat. So they did a lovely webinar on the state of science regarding social risk comprehensive instrument validation. Again, like the Accountable Health Communities Health-Related Social Needs Instrument, or the AAFP Everyone tool, or We Care, like any of those instruments that combine multiple domains in one. They did a webinar on just that topic. Next slide. So Gravity Project, as part of our evidence-based process, we approach evidence from multiple pathways. We convene subject matter experts in every social risk domain. And that means food insecurity experts, transportation insecurity experts, both housing instability, homelessness, and inadequate housing experts. You know, utility insecurity we just kicked off, and now we have experts in incarceration status and language access. And so that is our, that is how we ground ourselves in the evidence. And we also do an extensive literature review for anyone who's ever come to a terminology meeting. We are awash in evidence. We only are able to assess instruments that are in current use, because we do not assess instruments that are in development. They have to have been implemented. Nor do we create instruments, although whenever we do our work, our subject matter experts, after they talk with one another and analyze existing instruments, they always want to. It is a theme. For most social risk domains, the level of evidence for including in gravity value sets is a level of evidence of face validity. Does this instrument appear to measure what it's supposed to measure? Just basically. We raise the bar in some instances if the existing evidence is strong enough. And this is when SMEs consider it's important from a risk-benefit analysis. Examples of us doing this are our work with intimate partner violence and elder abuse, where they only accepted instruments of robust psychometric status. There is a move in the ecosystem to raise the bar when appropriate. Again, I mentioned with CMS that their incoming measures raise the bar for accepted instruments to instruments that have been tested against the gold standard when a gold standard exists. More to come on that over time. But again, the state of the science is that there's not very many gold standard instruments. So here we are at the present. Next slide. Okay, does gravity require? We can only publish it if it's public, right? So we haven't, so we do, but there is a public open access requirement. There are some instruments we've assessed in the past and they've been aligned, but it's of no use to anyone if we can't demonstrate the question methodology. But there are some instruments on the Gravity Accepted Instruments page which are of internal use and private, but we can't put them into LOINC or demonstrate them as part of our sets. So yes, Tom, that happens. Rare, if it's rare though. Something to note that's really important when we're coming to the socioeconomic, like financially driven insecurities. And so this is not the psychosocial concepts of perceived stress, for example, that we've addressed in the past, or social connection, but really the financially driven social insecurities. Is there's core dimensions across those base socioeconomic material need domains, so like food insecurity, housing insecurity, including all of its subtypes, transportation insecurity, et cetera. Those core dimensions are vastly published in the literature, including in the Foundational Measurement of Food Insecurity paper from Bickel, Nord et al., or Dr. Coates on Building It Back Better, right? So these are the things we consider when instruments are developed, is does the instrument assess all of these elements? So those dimensions are a core part of gold standard instrument development, as I mentioned, and they're really a core part of everything Gravity does, because we try to build concepts and find instruments that measure all of these things. And they're how the SMEs approach assessing instruments for inclusion, right? So we might be able, face valid might be an instrument that only assesses the absence of something, but we recognize that we might be missing the worry and stability elements in that approach. And again, the gold standard ensures that it has all of these elements rolled in. And you can see that in the USDA module and in the Housing Insecurity Index. Next slide. So all domain level, expert reviewed, face valid, and accepted instruments are collated on the Gravity Confluence. Again, this does not require link encoding. you can look at there, and Tom, this is what I was mentioning. So on the Gravity Accepted Social Risk Screening Instruments page, you can find every instrument we've ever assessed, right? And there are proprietary instruments that are there, or have been there. Instruments on that table can be filtered by social risk domain and their status in LOINC encoding. The Gravity team also includes on this notes and edits and updates to LOINC codes when relevant. And we're very, very grateful for our friends at LOINC and Registry. We just had a meeting with them on LOINC encoding today. We meet on a regular basis. We are very appreciative of the LOINC team. Next slide. This is a not live, so it's a screenshot, and my apologies for that. But this is a non-live view of what that table looks like, right? So you can see the name of the instrument, hyperlinks to the instrument, the domains in which the instrument references, whether it's in LOINC and therefore part of our value sets, whether we're submitting it to LOINC or whether it's outdated. And outdated means it was once in the ecosystem and it has been demoted from use. And then you also can see notes. And this is where we put notes on, any copyright issues we might be having, or notes on internal use, any note that we feel like is relevant and important for implementers, we put here. So if Gravity were to accept an instrument for health equity accreditation along with NCQA, and it was not ever a plan to have it be LOINC encoded, but we wanted to represent that it's face valid, this is where we would say that it was aligned, right? And it's going to be aligned by specific domains, like one of those subfacets of housing and security, and maybe meet some of them, but not all of them, right? Because everything gets broken down by measurable like subtype, as Lucy was mentioned. All right. Okay, so there's a lot of really great questions. So okay, no, Polina's just leaning into them. Fantastic, Polina. Thank you. Next slide. All right. Okay, so LOINC, this is really important. So when we take the next level, we've assessed the instrument as being valid, right? And our SMEs agree that it's valid. From a standards-based perspective, we LOINC encode nationally tested and implemented instruments suitable for representing a standard method, right? And Lucy, again, you were raising this point earlier. So all currently LOINC encoded instruments are national in scale, right? And you can see that through the instruments that are curated with FENIX, or the previous encoding of Prepare, or the encoding of WeCare, right? These are all instruments that existed in the ecosystem, or for instance, CMS leading the submission of the Accountable Health Community's health-related social needs screening tool, right? So when we submit to LOINC for the purposes of representing a standard, it is a national standard, and so those instruments have to be represented in a national scale. It's also just from a labor perspective, because there's a lot of instruments out there. But this also, so Gravity ensures that any complete gold standard is LOINC included. That includes all 18 questions on the USDA food security module, the complete representation of the perceived stress scale that we're working on right now, the full housing insecurity index when we lean into submitting that, because that's, again, the gold standard. And even if you're using a brief pragmatic instrument for an initial assessment, like for screening, those comprehensive instruments are fundamentally deeper assessment instruments. That's how they're designed. And in fact, when we were submitting the newly validated brief, but not very brief, household with children adapted food security module that the USDA and our friends at Children's Health Watch just created, they were very clear, this is not to be intended as a screening instrument, this is an assessment instrument, and we said, noted, right? Those ensuing valid LOINC encoded instruments are then the basis for Gravity stewarded National Library of Medicine value sets in the Value Set Authority Center, right? So that is what becomes these curated sets of LOINC encoded, Gravity accepted, nationally implemented instruments, and this becomes what NCQA points to in things like its measure, or CMS points to, or USCDI points to, or CMS points to, right? So when CMS is pointing to regulations like within the special needs plan guidance, it's pointing to our value sets, that like higher bar. So not just valid, but valid and nationally disseminated. And then, so though it's like I mentioned, so this is the fundamental basis for all of these for all data standards and electronic quality measures. Sure. Rob, thank you. Okay. Thank you, Rob McClure. Next slide. All right. Okay, I can fix that bullet. So at present, Gravity stewars over 240 value sets in the National Library of Medicine Value Set Authority Center across all of our activities, not just assessment instruments. We have standardized assessment instruments, diagnoses, goals, and interventions, right? All of those, again, are encoded in the standards that Polina was talking about. So the assessment instruments are one component of the NCQA measure or any CMS measure or those CMS guidance. The interventions are another. Our value sets support both. Next slide. And I'm not able to read all the questions, but we'll get to them. And this is an example of that. This is I think it's a live table last time I checked, but of course it's not going to be live in the PDF for the webinar. But this is what that looks like. And again, we presented on this table a fair bit over the course of implementation, but spreadsheets with those LOINC-encoded valid assessment instruments for each domain are also located on the value sets page. Again, this is for implementer use and ease of use. Again, thank you to the work of the amazing terminology team at Gravity, Hamali, Sarah Bahal, Monique. Like, really could not do this without Sarah Bahal and Hamali, all of their expertise. So here you can see the hyperlink to the instrument, the panel and its LOINC code, the panel name, the LOINC comment, the LOINC question code. The only thing we don't put down here are the answer list. We just have a hyperlink to the answer list, right? And you also can see on this table for food insecurity how those instruments, even all the different ones on the left, reference the hunger vital sign over and over and over again, right? It is the instrument of reference for brief food insecurity screening. And so it just gets repeated over and over. And it's open use, which is important. Next slide. So all instruments are assessed, again, just rounding down this. So, and when we are assessing any new instrument, we have to break it down by social risk domain. And Bijan, this is what he and I were talking about, right? So we take a big assessment instrument and we break it down into blocks. Like this is the transportation insecurity bit, food insecurity bit, housing instability, like housing insecurity, housing instability, homelessness, inadequate housing, and then we have to, so we break it into blocks, and then we have to align the existing standards all at the domain level. So any submitted instrument might meet validity requirements in one domain and not another. And we were just talking about this, right? So you might be perfect, you might be spot on for homelessness, but off track for inadequate housing. We do that with any comprehensive instrument, and that is the assessment we give back. And again, thank you for NCQA for clarifying that. Next slide. And so we have to break it down, and then this is what we do next, right? So any instrument is first analyzed to see if they leverage existing approaches. That makes it easy. Does the instrument leverage open existing approaches? It's really wise to do this from a data standards interoperability perspective. There's really a lot of really good methods out there. Again, it references existing evidence, research, and standards, and it also supports interoperability. So examples of that would be the validated Children's Health Watch Hunger Vital Sign or Housing Stability Vital Sign, right? Standard, evidence-based, domain approach, tested and validated. And so we look and see, like, does the instrument reference this? If so, then check, you're good to go, right? And then the second question we ask is, does the instrument leverage proprietary questions that require licensing? Hamali is a national treasure. It is entirely true. Does the instrument leverage proprietary questions that require licensing? An example we prepare. So if so, we have to default to that license holder for permissions, right? So we always have to say, I see this instrument's from Prepare. Do they have permission to use that instrument? And so then it's like a talk among yourselves thing, because again, we have to support instruments and their authors and their licenses. And then the next thing that we do is ask whether the instrument keeps the original methods intact, an example of fidelity. So all accepted instruments have a method, and that method is evidence-based. And so you have to use both of the questions from the hunger vital sign to say you're the hunger vital sign. You have to match the methodology appropriately to call it the hunger vital sign. That includes the questions and answers, and you can't take it apart. Right? So you can't say it's the hunger vital sign if you only use one question. You can't say it's the housing stability vital sign if you only use one question, right? So we have to honor the fidelity of the existing instruments. Thank you so much, Bijan. I thought of you. right? Because we, from an evidence-based process, really have to support those primary authors and their testing and evidence that they're utilizing, right? For us to say that it's accepted. Again, it's all important for evidence-based and instrument permission. Next slide. Every instrument has to be, so if there's a novel method, right? So we first look and see if it aligns with existing methods or is borrowing existing methods, and this happens all the time. Again, it's just often comprehensive instruments or just an assemblage of existing instruments. This happens over and over again. For instance, the AAFP Everrun instrument is just the collation of other instruments. Like the health leads approach is just a collation of other instruments. So we look there and try to see if that's happening. Janice, I'm going to finish this slide and I'll get to your question. So if it's a new instrument, every instrument again has to be assessed to ensure alignment with the domain SME's adjudication. So primary reason an instrument would not be accepted is not meeting face validity. If the question is not clear enough that the SMEs can establish it reasonably measures what it's supposed to measure. Another reason why it's not accepted, and this one's tricky and hard, but our SMEs have been consistent on this, is whether it's outside of the evidence dimensions of a domain. This problem happens over and over again. Wanting help with a material need, such as food, housing, and transportation, as opposed to needing help, right? And so most instruments that are validated start with a needing help cascading to wanting help to differentiate social risk from social need. That's very established in the literature, incredibly supportive of that. WeCare is a great example of that. Asking about wanting help after establishing need is best practice, but simply asking about wanting doesn't establish it within those measurable dimensions of the domain. Another example of not meeting validity requirements is just simply enrolling in a benefit. Like, even though we know the correlation between SNAP enrollment and food insecurity, simply being enrolled in SNAP is not a food insecurity screener. And so you have to independently ask about the domain. And then often when like, for instance, from a fidelity perspective, if we don't see an instrument has the evidence to modify it, we can't support it. Or if we are confused about how it hasn't been modified over time and it seems really antiquated, like sometimes our instrument authors are like, well, this was validated in 1940, it hasn't been retested, and hasn't been any further updates or evidence, and so we don't know if we can support it. So these are all historical reasons why instruments are not supported or moved forward. I'm going to say access is a really important thing in that last bullet. Like, does it, is it inclusive of all different types of genders, identifications, like partnership statuses? Like, if we are not inclusive in our measurement, we're perpetuating inequities. And so that lack of alignment with current best practices for how we define entities and relationships themselves is a major reason why things aren't accepted. Okay, this is a lot on this slide. Janice, and then Lucy.
Hi, thank you for this. I've been involved with measurement for like 8-9 years, and I did volunteer on the risk adjustment committee just because I wanted to know more about it. It was way above my head, but I learned a lot about adjustment versus stratification. And I also served on a panel with Sarah Scholl, who helped to develop the SDOH, probably what you're talking about, anyway, a couple of years ago. And so I am very aware of this. I just want to mention on the last slide, actually, if we could go back, the modification and well, what struck me is we haven't talked about, like modification or retesting. And some measurements kind of, they check them out every few years, 3 to 5 years is kind of average. And this is really important for people to realize. Whoever developed it, like NCQA developed this wonderful measure, it has to be maintained by that individual. That maintenance is very expensive. A lot of people don't realize it. And so, and then we look at that time, how often has this been used, and what are it opens up for public comment for everybody that is not aware of this. That is where, like Lucy's comment about there's only one, question, but this was the first SDOH big measure that really got out there, following CMS. So, the more we have, there's always people questioning it. But I just wanted to bring up the point about modification cannot happen without a real assessment and going through and comment and looking through all the literature, and then maintenance is something also to, that is necessary.
100%. And you're talking about measure maintenance, and that directly aligns with measurement maintenance too, which is like the instrument itself that was being referenced. 100%.
That's what I was
Yeah, for your leadership. You're definitely a leader in the measurement world. Lucy? Hi.
So I'm definitely not. This is really not my realm of expertise, and I'm so grateful to all on the call who know so much about this. Sarah, could you just comment on the second bullet? Enrollment in a benefit is not evidence of need. Could you just, why is that? Because presumably before they were enrolled, somebody assessed a need or not.
So it's not that it's not associated with need, it's just it can't attest as the presence of the need. Like, for instance, the USDA does not measure food insecurity on SNAP enrollment. There's individuals who are not SNAP enrolled who are food insecure. There are individuals who are SNAP enrolled who would not identify as food insecure. And so we can't use the enrollment in the need specifically as evidence of, like, for instance, there's tons of families that I take care of that don't qualify for SNAP, but they are still food insecure. Right, so that's why the food insecurity measurement itself is independent of the enrollment in the benefit. Associated with strongly, 100%, but not a screener or assessment of the need itself.
So could you please rule out, from my cynical perspective, that there's concern about fraud here, that being enrolled in a benefit is not evidence of need, that people want it, but if procedures were...
That is absolutely not. I can promise
Thank you. Okay.
I would never let that happen, and that's not the story.
Okay.
Yeah. Also, I just want to add to that is the need is like they could be on SNAP and they still have a food need, and they might be, sent to like a pantry. So even though they are enrolled, they might still have a need too.
So here we go. Okay, thank you. All right. So exactly true to Jan. I'm just trying to make sure that I'm doing okay. I think we're good on chat comments. Lucy, I hope I addressed your question well. I wanted to make sure there wasn't anything I need to update on this slide. That's why I went to the chat. Are we any other further questions on this? Good. Okay, carry on. Next slide. All right, you guys are the best. Just know that, as I mentioned earlier, the ecosystem is changing as we become more accustomed to assessment and as these measures roll out. Anytime Janice was talking about reattestation, like we develop measures about things to drive the ecosystem forward, and we develop instruments to drive the ecosystem forward. And then once it becomes best practice and standardized, we move to other things, right? And so just note that there are some existing gold standard instruments in some social risk domains and emerging instruments in other, and a federal desire for consistent measurement. Gravity is responsive to the ecosystem. So at some point, if the collective of gravity and all of our subject matter experts want to elevate the bar for inclusion in gravity value sets to a higher level of evidence, we can consider that in time. We're not there. Reiterating that CMS regulations and regulations may and some already propose to raise the bar, again, as I mentioned, for acceptance for domains with existing gold standards, such as food insecurity, to instruments that meet basic sensitivity and specificity requirements against that instrument. So CMS is already stating, and the technical experts involved in that measure are already saying that that's the approach and desire there because the level of evidence dictates that. If you ever want to know from the CMS standpoint about how they're referencing gravity standards in their quality measure program, ASTP STOH Learning Forum had CMS present within their implementation, measurement, and evaluation series, and that's available publicly. Next slide. Whew. We're doing good. As I mentioned, we really try to work with entities and supporting them and how to align with existing evidence. And, again, Bijan, thank you for your patience, and many other entities. I get emails about this all the time. So settings that want to maintain the way they've measured forever, such as the want component, really are, one of the things we advise is just mimicking the model of We Care, which really clearly cascades needs and wants. Again, that's best practice. That is the work of our leading social determinants of health expert, Dr. Arvind Garg. It really is that differentiating of social risks and social needs. And, we really try to use patient-centered and person-centered approaches. And so that's something we advise. Like, you don't have to change very much. Leave what you have, start with a question that asks about the need first. We do try to advise about the incoming regulations because we want to make people know what's on the horizon. And then we also are just within the housing element, Lucy, we try to be prudent and supportive, right? So if the existing SNS measure or health equity accreditation only needs you to do one of the different housing insecurity subtypes, we try to say that going forward. We just learned that, so it's wonderful to know. And we do try to advise entities on how to align on the glide path in time. Next slide. I thought we were going to have 30 minutes, but we had a lot of questions during, and I hope you feel like your questions have been supported during the process. Another thing that we do in our work at Gravity is actually work with measure developers to try to support standardization. So an example of this is how we collaborated with our friends at Children's Health Watch and the Housing Stability Vital Sign, because the previous existing question did not differentiate between history of homelessness, which is housing instability, and current homelessness, which is homelessness. It is phrased at any time in the past 12 months were you homeless or living in a shelter, like parenthetical, including now. What Gravity worked with, and again, is always trying to maintain existing legacy measurement and not supplant local knowledge, right? We wanted to support specification between housing instability and homelessness without supplanting the existing question. So we worked with the Children's Health Watch team, and very simply, we just aided instrument authors in adding an additional cascading question, and that will come in the ecosystem very shortly. So if you answer yes to the third question of the housing instability vital sign, there shortly is going to be a third, like a cascading question. If yes, are you homeless or living in a shelter now? Yes, no, right? And that will differentiate the housing instability entity from the homelessness entity and support specification, which is, again, one of the goals of measurement. And this should be at a different bullet, but the gold story is here is we always try to support tested logic and legacy when we can. We recognize that entities have been doing this work for decades, and we do not want to disrupt things if we do not have to. So that will be released in a LOINC update soon. Again, just add an additional question and you're good. You do not have to supplant or displace anything else you've been doing up until that time. Next slide. Whew. Okay. And then once an instrument has been accepted, either after original submission or after modification, again, only those national implemented instruments are submitted for encoding and LOINC, right? So we talked about how we work with instruments that have gone through the formal SME process as we're working on domains. At the same time, if we have a new instrument that comes across, we only work with, we only submit nationally implemented instruments for encoding and LOINC. And again, not all programs require LOINC encoding. The Health Equity Accreditation Program does not. The SNS measure does. But if an entity is part of a program with LOINC requirements, mostly quality measures, right? Those ECQM, electronic clinical quality measures, it's an important thing to note. Again, we want to support you and give you advice that's going to support you. So if you are thinking of needing to attest to the SNS measure, LOINC coding is important. And then if you are watching the the CMS measures coming down the pike, we try to say that as well. If you're thinking about USCDI, LOINC encodings as well is important as well. So just trying to support entities in the vision to future regulations. Next slide. And I think we're good. We're almost done. And I'm sorry we didn't have the question answer period, but again, I hope it came during the talk. Just in general, the base gravity instrument acceptance path is really an assessment of simple, usually face validity. The inclusion of instruments in gravity national LOINC encoding value sets is an assessment of interoperability and standards, right? Setting a standard, and again, quality measures generally support standards. If you think about other screening and intervening measures like depression screening and intervening, there's only like 8 measures in the whole set, so gravity's acceptance is actually quite large in comparison. And again, so in this case, the Loink encoding is, not just does this instrument appear to measure what it's supposed to measure, which is that face validity element, but can the information from this instrument be reliably and consistently shared across entities? Next slide. This is the final content slide, I believe. Okay, again, in summary, the path. The first thing we do is analyze with any instrument is analyze for existing open source domain level instrument alignment. And if the instrument leverages if the submitted instrument leverages the existing instrument with fidelity and has any required permissions, it's accepted. And then if it's not aligned, we assess it for validity. If the instrument meets basic domain level validity requirements, it's accepted and added to the Gravity accepted instruments table, but that does not mean it's Loink encoded. And then we Loink encode nationally implemented instruments. If the instrument meets those validity requirements and it's nationally implemented, it's submitted for Loink encoding. And then once released, it's part of those Gravity domain instrument value sets, right? So that's our 3-step process. And again, each of these different elements have different use cases and purposes, but they're just separate insofar as the scope and intent. Next slide. I think we're good. No time for open discussion, but I hope you feel like we addressed all of your questions during the call. Again, thank you, NCQA. Polina, thank you for coming and talking about NCQA and talking about how the SNS measure and health equity accreditation intersect with the Gravity's work. Incredibly honored and grateful for your attendance. I hope any entity that sent an email to us regarding acceptance understands a little bit more. And now we at Gravity understand more too about how to participate and collaborate. Our next meeting is November 21st, and we look forward to coming back to you. Any other final thoughts before we close? We have 4 minutes. We can go on to the next slide, which has the meeting information. Again, you can always find our materials on the Confluence, and the webinar will be there, right? So in the resource for implementation, it'll be there as well. It'll be in the meeting recordings and in the resources for implementation set. Any other final thoughts? Thank you, friends. I hope I didn't miss a chat. There were so many. I think we did a good. Yay, I'm glad you thought it helpful. And again, thanks for all the topics for future implementation meetings. I think the vendor-based one is a great idea. We have lots of opportunities to keep on disseminating, and we will see you on the 21st or in a few minutes when I kick off the next call. Thank you all.
Thank you, Sarah.
Bye.
Thank you, everyone.
Bye, Polina. Thank you, NCQA friends.
Thanks,
Bye.
Sarah. Take a 2-minute break.
I know I will. Bye.